Thank you very much. And we are coming to the next presentation. And this is Professor Омельяновский. Vitaly Омельяновский, who will speak very briefly. Vitaly. Yes, good afternoon, dear colleagues. I will try to show my slides very briefly, and I will shorten it as we are already behind the schedule. Hope you can see my slides. Yes, that's great. Please make it full screen. Just a second, I will. Yes, please make it full screen. Well, hope you can see it now. Yes, positive. Thank you very much. We can see your slides properly. So, dear colleagues, my topic sounds a little bit of provocative. So, the real-world data in the paradigm of clinical guidelines. When we speak about providing medical care, we have few documents shown here on the slides. They are approved and confirmed by different bodies and regulators, but these are the documents that guide the medical care today. If we look how it looked like, well, they were all very sporadic and separated, not closely related in between, not always harmonized. Now, this slide that all my colleagues showing, so how can they be linked? How is done the complex assessment and the list of the drug for the essential drug list, and then how it is reflected in the clinical guidelines, how it is related to the standards, etc., with the quality criteria, with disease-related group, and to a certain extent, they influence more and more to the program of state warranties. I'm not speaking too much about clinical guidelines, although it declared like a main topic of my presentation. I will say a few words. Just the clinical guidelines today is a legal document, and until recently, they were all similar in their significance, national or associations from the medical institution. That is why we had multiple guidelines, and by 2016, in the rubricator of the electronic library, you could find more than 1,200 of clinical guidelines. Unfortunately, these guidelines, well, some of them were used, some of them not. They not always use evidence-based medicine, so they use different scales of level of evidence and level of recommendation. So 1,200 recommendations. So we could say one thing. Not all guidelines had the best quality, and they used very different approaches and very different scales. Again, here, we are showing different approaches. So that is why it was very difficult for the clinician to understand which way to go. So some of them don't use approaches of evidence-based medicine. So I'm not going to speak about the challenges. Now we know that the state policy and the clinical guidelines are organized differently in different countries. Here is a slide with a number of countries, and these are clinical guidelines. Some of them just for the Europe, some of them just for WHO, some of them applicable for the American continent. But the main point is here that all these clinical guidelines, they are of different purpose and different coverage. And it is very clear that in this or that situation, there are national clinical guidelines. Let's look at the point of creating clinical guidelines. Most frequently, this is support of HCPs. For example, in the UK, this is support of HCPs and courts. In the United States, support of HCPs, courts, and also reimbursement calculation, insurance. So the point is here that traditionally guidelines, which are created by professional associations, this is ideology of treatment. Although in the UK, there are clinical guidelines which are designed by professional communities, and there are guidelines that later assessed by the NICE, by the biggest regulator, and then it's applicable in courts. This is the basis for the national health system, and this is a basis to create tariffs, HRG, which is the analog of our disease-related groups. So it's similar to us, but we have clinical guidelines that don't go from the clinical and economical assessment like in the UK by NICE. So they are made on the basis of evidence-based medicine. And then there are standards which are in the basis of making tariffs. Today, the structure of the clinical guidelines is approved by the order of the Ministry of Health. Requirements also approved by the Ministry of Health. So the most important requirement is the evidence of efficacy and safety of medical intervention, keeping in mind principles of evidence-based medicine. And now the questions: real-world evidence or real-world data, where they are here, absolutely absent. Today, the structure which is existing, telling us that no matter, so if there is something else, they should be merged together and signed by different associations. They are approved and by professional associations. And today we have to say, I don't know, there are different positions. Some people approve, some people disagree, but everybody is saying that there are systemic approaches for the design of the clinical guidelines. They all have similar structure and they can be compared in between just because Ministry of Health approved the requirements. Clinical guidelines should be designed or initiated by the profile associations, pulmonology, cardiology, oncology, rheumatology, whatever. And we call them vertical specialists because they launch the start of the clinical guidelines design. But then we understand that the normal clinical guidelines applicable, those that are interdisciplinary, clinical guidelines that described instrumental and lab test methods, drug treatments. Ideally, they should be done by the interdisciplinary team. And then, in the order of the Ministry of Health, it is mentioned that with the establishment of the clinical guidelines, the working group should be done. And here you see vertical specialists, pulmonologists, cardiologists, oncologists, and at the same time, associations that, in fact, reflect the interests of horizontal specialists. So those where the product of their activity is used in frame of different clinical recommendations. So these are emergency doctors, clinical pharmacologists, functional diagnostics, chemotherapists, etc. So today, the policy to design the guidelines looks the following. So vertical specialists, they initiate the guidelines, and horizontal specialists initiate the design of methodological recommendations that are in the basis or just an application to make the clinical guidelines. It's pleasant to say that it's happening. What information is included into the clinical guidelines? So first statements are done. They should support by the level of evidence and a level of recommendation. And there is assessment that is done and it's done for each statement. Then the question, where is the place of real-world evidence? So there is no place of real-world evidence here because in the scale of the evidence level, real-world evidence is not presented. So it's position 4 or 5 in diagnostic involvements for drug treatment. And this is a level of evidence. The standard of the medical care. This is a document which is based upon clinical guidelines. The standard of the medical care. This is a document which is designed based upon clinical guidelines approved by the Ministry of Health. That includes medical services, drug treatment, conservative treatment, medical devices, blood components, and type of medical nutrition. But the drugs which are included into the clinical guidelines, they can be included into essential drug list or may not be included there, but they should be counted only the ones which are included in the essential drug list. In the procedure of the complex assessment, real-world evidence also is not counted. That is why this is the area for future work, for future discussion, and understanding the role of real-world data and real-world evidence. in the forming of the evidence base on particular technologies. Now, a few other moments. Clinical guidelines, methods of treatment, standardized models, and the standards of medical care. Standards of medical care, standardized models, they're indirectly related with disease-related group. And based upon that, we calculate the tariff of treatment and indexes of disease-related group. And the separate topic, which is actively discussed today, is the option to use drugs off-label. And here I would like to say that possibly the real-world evidence and the real-world data, their role is becoming more and more relevant. Because today, in neonatology, for example, in pediatrics, in oncohematology, quite a lot. For example, in oncology, when we treat TB, we actively use drugs off-label. Off-label use can be included even in the clinical guidelines, but they should be marked by asterisks, because these are drugs that are administered not according to the label, but off-label. But at the same time, in pediatrics, in neonatology, real practice looks the same, that these drugs are sometimes up to 60% or 70% of indications of prescriptions. And in oncohematology, it's also a very big pool administering drugs off-label. But if they're mentioned in the clinical guidelines that the drugs which are off-label cannot be calculated by the standards. That is why today, our center designed the approaches how to use drugs off-label. The objective is unification and identification of rules in the clinical practice. Then in the criteria of quality assessment of the medical care in the clinical guidelines and in the standards. And this method today is clearly showing the off-label place in the standards of treatment in the clinical guidelines. So this method is transferred to the Ministry of Health, and in the near future, we are expecting the assessment. In order to introduce this gradation of off-label drugs, to assess and to identify the option when off-label could be considered as standard and when it cannot be considered as standard. That's why we offer this method, but it will require the change of Federal Law 323 and some other legal acts. That is why in the near future, we planned the roundtable in the Council of Federation to use drugs off-label. So we discussed these approaches, what to do with off-label drugs, and I'm pretty sure we will witness how it will develop further on. So the key conclusions of what I said before. So currently, the principles of providing medical care is changed because there is bigger role of clinical guidelines, because guidelines are approved by the Ministry of Health through the Scientific and Practical Council of the Ministry of Health. There are some rules to avoid a duplication of drugs. The standards should be based upon the clinical guidelines and unified approaches, although neither in clinical guidelines nor in the complex assessment, neither in the standards of the medical care, we never ever see the place of the real world data and the real world evidence. I think in parallel with orphan drugs, in parallel with advanced treatments, cell treatment, gene treatment, in the areas where there is a limited number of patients, or in cases when we launch risk-sharing approaches, so-called innovative methods of drug supply. In those areas, the financing would be provided based upon the effect of the product, value of the product, and in parallel, we will collect the data on the real-world practice, and without real-world data, we will not be able to do that. So from my point, in the near perspective, the real-world evidence and real-world data would be very important, especially in advanced technologies, where there is very limited database, where without real practice, we will not be able to identify the place of new technologies in the treatment of patients and in the proper financing. Thank you very much for your attention. Thank you very much for brilliant presentation. Any questions to Vitaly could be referred later on, and we will send him all the questions at the end of the event. So thank you very much. Thank you very much. Have a good day and goodbye.